So I invite Dr. Anand Gnanaraj to give his talk on tips and tricks of retrograde PCI through septal collaterals.
Specifically to septal collaterals and what the challenges are when you do septal collaterals. So before going retrograde, I think we all should be sure why we are doing retrograde. There should have been an antegrade attempt. There should be a long segment. Should be good interventional collaterals and definite expertise in hardware with retrograde procedures. The basic challenges are probably the first few are related to the septals. You have to find the right septal. It's not easy. Angiographically, a lot of septals look like the right septals. But once you take the wire inside, the whole game changes. Then, of course, navigating the septal, getting into the PDA, and then crossing the distal cap, then entering into the antegrade guide. So, if you finding the right collateral itself can be a little challenging during angiography. So, one of the ways to do that is to occlude a major contributing collateral. For example, if you're looking at an LAD CTO, there may be a large apical collateral which supplies the LAD. That is usually not easy to negotiate. So easier is to just occlude it with a small balloon. The important part is to occlude it with that only at 1 atmosphere so that you don't damage the collateral. Then you can visualize the other collaterals better. And I'm sure all of you are familiar with this classification. The most important part is the tortuosity and the diameter of the collaterals. And the tortuosity AD ratio should be, ideally less than 2. So that is when you can cross relatively easy without traumatizing the collateral. When you see crossing the collaterals, the most possible option is LAD to PDA because that 75% of those cases have good collaterals. And we do see angiograms like this. You see a lot of collaterals, but most of them, becoming capillary-like, and you will not be able to find any of them. And when you find one collateral which you can visually connect from LAD or the septal to the PDA, that is the most promising collateral that you should take. Again, PDA to LAD, again, only 50% of them have adequate collaterals, and even that 50%, the anatomy may be slightly different. When you're looking at the RAO caudal view or PA caudal view, the wire may appear to be going away from the vessel in the initial segment because you can see on the right side diagram that the PDA lying centrally in the posterior interventricular groove may give branches on either direction. So you have to be a little careful at that point. Once you enter into the right collateral, then things are relatively easy. This is a CT coronary of the collaterals. You can see in the cross-sectional view LAD on top and PDA in the bottom. So when you cross septal collaterals, you take RAO cranial for the upper 2/3 of the septals because as you can see in this view, the upper 2/3 of the collaterals should be crossed in RAO cranial and the lower 1/3 should be crossed in RAO caudal. Because in cranial, the lower 1/3 will be grossly foreshortened and you cannot predict in which direction the wire is going and or how far it has gone. Epicardial collaterals, of course, it's not a topic of discussion today. They are a different ball game. So crossing may be really simple and easy, sometimes not so simple. For example, in this case, it probably took 10 seconds to cross from the proximal septal into the PDA. Things may not be this easy all the time. And even if you can see how easily the Corsair crosses, this was done a long time ago. This was the original Corsair. Even the large sized Corsair just went smoothly. So there are times when you have patients who look like they are good collaterals, but then they take your life out of the procedure. So this is a young patient with an inferior posterior MI. So initially he had actually a flush occlusion of circumflex with a lot of thrombus and an RCA CTO. I didn't want to dilate the circumflex because I was worried that the thrombus will prolapse into the LAD and that was the only surviving vessel. So I put him on low molecular weight heparin and took him for PCI of the RCA first. And you can see that there seems to be a lot of good collaterals, but it took about more than an hour to just get beyond this. So at one point it looked very promising, like this. Then you take an injection, then you realize you are in a completely different plane. So the only option you have is to surf multiple times. Again, you see the wire looks like in a good position, but it's not in PDA. Then, of course, finally, after multiple injections and multiple attempts, this procedure overall took about 3.5 hours. And you can see here, now we are in the PDA, but facing the opposite side. So now turning this wire into this side is sometimes very tricky because the point of junction is sometimes a little vague. You have to again take the wire, give a very sharp bend, and then go back. We have, of course, microcatheters, Corsair Pro, XS Pro is, of course, amazing. It can go through almost any channel. Caravel, the less expensive option. Fine Cross, and the other three, of course, we don't use for retrograde. Sasuke, we don't have yet. I think once we have Sasuke, we can use it for retrograde. And especially in the last scenario where I showed when your wire is clearly in the PDA but facing the other direction, guides like Sasuke are very useful. Sasuke has all these reverse wiring options, which is going to be quite useful, especially retrograde. Sometimes penetrating the distal cap is really hard. You go through the septals because you don't know exactly where the distal cap is, and crux can be quite a challenge if it's not a sharp tapering distal. This is one of the young patients who had an LAD and an RCA. We've stented LAD, went into RCA quite easily, but at the end we just could not cross that segment. And it took a long time and multiple dilatations. A reverse cut was not fully possible because the balloon wouldn't go. So we had to do something like a granuloplasty and then finally enter into the antegrade guide. Then, of course, the problems when you cross septal channels. This is a strange patient who's a post-CABG, was admitted multiple times. He came with actually a left main LAD stenosis, and I had stented his left main to LAD about 3 years before this. He was lost to follow-up, then came with severe LV dysfunction and refractory heart failure. That time we had again stented his left main to LAD because he had a restenotic lesion. Then again he came with pulmonary edema in 2-3 days. So this time we had no option but to try the RCA. So you can see that the septals are filling quite well. So didn't have much worry about it. This is a bilateral injection. Immediately after this injection, actually he arrested on the table. He had VF and we resuscitated him. Then I thought, anyway, the only option left was to do the PCI. So we wired, went into the PDA, which was not difficult. You can see that this is the tip of the microcatheter. I'm injecting through fine cross to see the distal anatomy. At this point, again, he had VF. This time we had to resuscitate for about half an hour. But once the catheter was out, he stabilized again, and anyway, finally we finished this PCA antegrade. Then again, this was a relatively reversible situation. Sometimes the donor artery gets very badly compromised. For example, this patient, you can see that the first septal is almost the size of a circumflex. The LAD CTO, when we were attempting, the patient started having symptoms because of the proximal lesion proximal to the septal. So I dilated that and dilated the diagonal, and I was about to stent. Then he had severe pulmonary edema, lost the septal. He basically had acute coronary thrombosis for the cause for which I still don't know. Then I had to rewire, balloon it, multiple massages, and it was a terrible, terrible nightmare because losing a septal which is supplying a major dominant RCA is a disaster, and especially when the septal is so big. When you have multiple septals, usually it's not a big problem. And we should also realize that retrograde procedures do come with more complications, more composite endpoints, but I think with expertise, that endpoint keeps reducing. So in summary, the septal collaterals are probably the best collaterals to use for retrograde and the safest ones to use for retrograde, and the highest success rates will be from LAD to RCA. And channel dilatation with 0.75 or 1 millimeter balloons can be dried extremely cautiously, but you need the over-the-wire balloons. Septal hematomas, when they happen, usually are innocuous, but can be quite serious if the septal hematoma extends, and we should have the expertise to puncture back into the right atrium. And crossing the collateral is just one step. I think everybody overestimates the importance of crossing the septal and getting up to PDA. A lot of trouble lies ahead usually beyond that point.
How will choose the collateral to how you to enter, which collateral is suitable for the retrograde person?
No, usually we enter into the largest and the most visible collateral, take an injection from the microcatheter.
Okay.
And if you see a one-to-one connection, visibly you can track the entire collateral from top to bottom, you take that as the first choice.
Okay.
If that doesn't go, then you have to do surfing. But usually nothing happens. 90% of the times, 99, nothing happens.
Yeah.
It's usually when you perforate and don't realize and push the corsair over it, that's when the problem starts. Okay. Wire alone usually does not cause much damage.
Okay, thank you.
How frequently you have had to dilate the collaterals?
2-3 times so far in the 10 years.
Not many, and
Not
try to avoid that.
Because after Corsair Pro especially, it goes through most of the collaterals. Recently, we had a case in GH where Fine Cross did not go, Caravel did not go, Corsair Pro did not go. Wire was already in the RCA. But unfortunately, there we didn't have an OTW 1 millimeter balloon. So we had to abandon that and go antigrade. But I think it would have really helped in that case.
Dr. Anand, very nice. I think good cases you've shown.
Yes, please. Not filling enough. Usually there are tight lesions in the PDA also. I mean, something. So the safest option is septal. At least give it a shot. It's like first antigrade and then retrograde, something like that. But if there are no septals, then definitely epicardial.
Yeah, I had one question. You showed in one of your slides amplitude of movement and the diameter of the collaterals. Does that have significance? Is there any cutoff or only hit and trial method whether the particular wire is crossing or not? Diameter of collateral. Yeah, any cutoff for that? Is there any reason?
No, there are times when
amplitude and diameter. Is there any?
Yeah. 2. The ratio should be less than 2. So if the curve is much more than the diameter of the vessel, then your wire will have more difficulty in crossing.
So that's a marker of tortuosity, right?
Tortuosity. Yeah, more for epicardial rather septal.
Yeah, then how will you decide which microcatheter you are going to take in a specific case?
Initially, we used to take Corsair when Corsair was the only one. Then because Caravel was lesser of a diameter, we took Caravel. These days, if this collateral is good, if you crossed with the wire, you take an injection, you can still see the collateral filling, you can use any microcatheter. If your wire is crossed, but nothing else is flowing through that, then I think XS Pro is the best, or Caravel.
Okay, thank you, Dr. Anand. It was a wonderful presentation.
Thank you so much.
It was wonderful to have you here with us.